Divisional nurse for medicine. I'm in post, so on a secondment at the moment. So thank you so much for inviting me back to this year's conference. Was anyone at last year's conference that saw me speak? A couple of people. So just to take a slightly different approach. So last time we spoke a lot about the withholding treatment policy, embedding that, some examples of how we've embedded it, and I'll probably pick up on what we were just discussing a moment ago, and that does fit quite nicely into a rapid review. So the concerns that you were raising about the patient making allegations about having property stolen and then their behaviour towards you, so that probably fits quite nicely here. So I'm going to talk about something that we do in medicine. It's not something that we do all of the time because people will manage and put mitigations in place where there's AVH. It often occurs in sort of extremists or where we think there's going to be repeat incidents. So we have rapid reviews and we have case studies. So I'll just tell you a little bit about those. So these are basically multidisciplinary meetings where we come together to discuss one or more incidents where there has been violence or aggression towards our staff. And that might be verbal, that might be physical, that might be both. But it's where we need to put measures in place to both help to further de-escalate situations, if that's possible, support our staff and make a decision about whether we withhold treatment for a patient and actually have them discharged from the organisation. So why do we do it? Because we know that staff are increasingly being exposed to AVH. We've again had the highest reported AVH incidents in the organisation. I'm sure some of you watched the news a couple of weeks ago, where a couple of our colleagues from the emergency department and wards were on and were sharing their experiences of AVH. One of the things that really stood out to me was that Nottinghamshire Police received the highest number of reports of assaults against NHS workers, is what was described on the news. Now, on the one hand, that's really worrying because that means that there's a significant number of NHS staff being assaulted or verbally abused. However, my last message for those of you that were at the conference previously was please report it to the police. So I'm not taking single-handedly the glory that we're reporting more to the police, but it is so important. And actually, I was reassured that the police were getting our calls and getting it reported. We're still not doing it enough. Our nurses are amongst the most frequent reporters to the police. So if we have any other professionals here, any administrators, please can you also report it? I don't see the data texts coming through from allied health professionals, medics, administrators. What I see typically is nurses reporting, and I know that that is not representative. I know there are many more of you that are affected, so please can I ask you to data-text, please report to the police. And I'm sure Neil and Sarah sort of reassured you around those processes. Because I still have people saying to me, I don't want to give statements, I don't want to take this any further. But that's how we're going to really have an impact on these individuals that have capacity and come into our organisation and choose to abuse us. So we have to make a stand, we have to, have the courage, and we will support you in whatever way we can. I've had some feedback about what is the support that's given if people are going to court, so we give statements, etc. Just to say at this point, if you report it to the police, you have to let your employer know if you want support. We can offer that once we know there's been an incident, but the police don't come back to us and say, oh, your member of staff's going to court with a statement to give some evidence. So if you would like support, we will wholeheartedly give that, but please let us know. It's to do with confidentiality and other data users, but you can come to us and say, I would like support, I'm going to go and give evidence against somebody that assaulted me. So that's my ask for today. So if all the police, and if you need support, when you're going to give evidence, please let us know. So back to rapid reviews anyway. So these are multidisciplinary meetings, and it can include a whole host of people. So nurse and charge therapists, other professionals might be drug and alcohol liaison, it might be IDT, it could be the GP, think about case conferences more so. Police join us, security joins us, Sharon joins us. So, think about who do you need including in this multidisciplinary discussion? Who's going to be able to help you to make a decision on the best way to care for this patient, to support the staff, and whether or not you should implement the withholding treatment policy? What we would like to see more of is the staff affected by AVH contributing to those rapid reviews. Now, that can be difficult because you might not be on shift. So when you do your day text, please include in that some of the detail about how you've been affected, and then we can make sure that your views are brought into those rapid reviews. So safeguarding also often involved, and sometimes we do involve the legal team as well if we've got some really difficult decisions to be made, and I can give you some scenarios in that. But just because people aren't available, it shouldn't stop the meeting from proceeding. The rapid reviews should take place, in our view, how we work in medicine, within 24 hours of the request in the working week. Some of the criteria, so a rapid review occurs for inpatients, and any of the following can precipitate a rapid review. So, are we likely to see further AVH events? Are the current things you're trying to reduce the risk not working? At the request of the ward or MDT. So that's not all of these, it's any. If you say, I feel like we need a rapid review, I'm really worried, this is going to continue to escalate, the staff are really concerned, please ask for a rapid review. And if there's an AVH alert in the system, so as an example, we have got some people that access our organisation that have got alerts on the system. So, for example, there might be a yellow alert. So this is an official letter and warning that goes to an individual to say, your behaviour in our organisation is not acceptable. We will not allow you to treat our staff like this. If this continues, we will look at excluding you from our organisation. So if there's a yellow alert on, there will also be some actions. So if that patient comes in and they haven't followed the instructions that have been given and they're abusive, ask for a rapid review, because actually they've not adhered to what our expectations are, and we can then pursue and look at excluding them from the organisation if that's appropriate. For a case conference, this is when the patient has been discharged. So say you've had somebody verbally and physically aggressive towards you, it's been determined in a rapid review, they don't need to stay in hospital, their care can be managed in the community, and we're going to remove them from the organisation to protect our staff. They have capacity, the care can be managed in the community, the risk to our staff outweighs the risk to them being discharged. They're discharged from the organisation, but they might be a high intensity service user, they might have a chronic condition, and we're expecting them to come back again and again. That's when we'll bring in a case conference. So that should happen within 4 weeks of the patient being discharged from the hospital. And again, it's the same group of people that might come together, but we might bring in community services. So most recently, I've had community mental health team meetings, GPs, specialist nurses that are caring for patients in the community. So you'd widen the scope of the meeting to include other professionals within that. Just with the case conference, we might have already had a rapid review, we might already have had a case conference, but the patient comes back in and still behaviours continue. So has the action plan not been effective? And then we can explore that again. And again, if anyone requests it, provider. So I've got a case conference today. There's a person who is deemed a high risk to the community, to our organisation. They may access our services in the near future. We're meeting today to put a plan in place with the mental health services, with the emergency department, and alerts, safeguarding, police that will go on the system. So these are things that we're already doing, and you might become more aware of them as you're looking at the systems and see these alerts popping up. We've drafted a document. Sorry, I know it's really wordy. I'll try not to read off it. So we've got a document that we use just to prompt us, and I've shared it before, and I'm more than happy to share it again, and you can adapt it. It's not a document that's within the policy. It's just something that we've sort of built up and adapted within medicine that helps to guide us. We look at, first thing is, can we withhold treatment from this patient? Review their capacity. If they do not have capacity, the answer is no. You cannot withhold treatment, and we go down another avenue. But I'll talk about if somebody does have capacity, what we'll do. We then look at their current clinical condition. So if they were to be discharged, what's the risk to their life if they were to be discharged from hospital at the time? Are there community services that can pick up their healthcare needs? If they are, then we can look to discharge. What are their social circumstances? So are they homeless? Are they waiting for a package of care that isn't available yet? So we consider all of that as well. And what actions have we taken to date? So if you don't know the withholding treatment policy in detail, please do review it. It's really, really important for you to understand what the steps are. I hope not to repeat things, but the stages are, we have the conversation with the individual and explain it's not appropriate, we will not tolerate this behaviour. You can also, at the same time, if that's not a second event or it's of such a serious nature, give them the patient information leaflet. That can be given to patients or visitors. Then, the next thing is the acknowledgement letter from you as a division. Now, I was initially the one that gave those letters. That has now been devolved to the clinical areas, and they put my name on it. So that's where we say, on this date, at this time, you did this is not acceptable, we won't tolerate it. If it continues, we will do A, B, C. So that might be phone the police have not already phoned. It might be we will consider your continued care within this organisation, and that goes to the patient. So that all should also be uploaded onto Datex so that Sharon and the team have got that evidence there as well. So when we go through, we'll say, well, what have you already done? Have you given a leaflet? Have you had a discussion? Have you given an acknowledgement letter? And we can agree at that point what to give. Now, in some circumstances, we do all three at once. Because it's of such a serious nature, you're not going to wait for another event. So this is the leaflet outlining, this is the letter saying we won't tolerate, and we've phoned the police, and we're going to be holding a case conference to discuss whether you can access our organisation in the future. Then we look at, we've made a decision there, can they be discharged or not? And it's based on those core principles, whether they've got capacity, whether their risk to their life is so high, and I have had two circumstances where that's occurred and you couldn't discharge the patient even though they have capacity. And then we move on to the mitigations to the staff. So, if you can discharge the patient, that's a mitigation to the staff, isn't it? That's the staff protected. Off you go, you're being discharged, and then there'll be a follow-up case conference about your future access to our services. Staff are protected. If we can't, what else can we put in place? So, for example, I know we've got the scenario described here, and it's not dissimilar to the patient I'm going to reference. So, the patient that I'm referring to was on a level 1 area. He was very unwell, but did have capacity. If he were to be discharged at that point, he would have probably died. So, we continued with his care, but many of us had a discussion with him. We met with, or the team met with a member of staff and explained the situation. We looked at where that staff member was working because it was one particular member of staff that was affected. Supported them, explained the situation as to why we couldn't discharge the patient at this point, but we would have regular reviews to ensure that he was discharged. What support from a wellbeing point of view could be put in place? Environmental changes, that was more to do with where the member of staff was working. And then we looked to see, is there any training and education that we can put in place? That's a longer term plan. But we have done some focused areas. So on Southwell, for example, we had a lot of AVH in a very short period of time. So the educators went into Southwell and trained all of the staff within 2 weeks around de-escalation techniques and things like that. So we have done that parachute approach to education, but it is more of a longer term thing. So we identify the staff support needs. We send an email which acknowledges receipt of the incident form. It details the wellbeing matron. It details the support that's available. I know in clinical areas you also think the team. This is in addition to just to sort of bolster that support. And we've also got all the support mechanisms, PNAs. But again, it's very much nursing focused. So we will send the emails to anyone that puts a day text. We've sent them to doctors, we've sent them to therapists, but we don't get a lot of feedback about that. So please do use those services. We will then determine what information we need to share on Nurse Centre, those alerts. So what Neil was just talking about with the patient, you can put an alert on, must be accompanied by 2 members of staff. That's dead easy to put on Nurse Centre. You can put additional alerts on where you might put a bit more detail. We obviously have to be aware of information governance. So if you need any advice on what can be included, please do get in touch with your matrons and lead nurses, Cheryl and the team. It will go on there if they've got a yellow or a red alert. So you'll have that information as well. And something that we're getting better at is sharing the information with our external partners. So the police, EMAS in particular, EMAS do not often get informed about these significant risks, and they are probably more vulnerable because there's one person driving, one person in the back of the truck with the patient. So we're doing a lot of work with EMAS. They've got some challenges around if the patient's name's not known, they don't know who they're going to, but we are working with them as well. And then to plan the case conference. So at the end of that meeting, plan the case conference. When is it likely the patient's going to be discharged if they're not being discharged today? We'll get that put in place. I'm not going to go. It's very similar, like I described about the case conference. Please ensure that any consideration for withholding treatment is escalated to your divisional, deputy divisional nurse. And then that will be escalated to the Health and Safety Director and Executive, Sharon and team as well. Has anyone been involved in Red Card, understands what a Red Card is? So this is when we put an exclusion in place for up to 12 months. So that patient cannot access our services except for life and limb threatening. So that's essentially your emergency department, critical care, emergency surgery type situation. So outpatient appointments they shouldn't be coming for. So in those case conferences, you might have to have a discussion about that. So my patient, as an example, is a respiratory patient and has a long-term condition and accesses outpatient services. So we're having to put in place provision for referral to another organisation. So it does get really complicated. It's not as straightforward as just saying you can't come to our organisation. We still have a duty of care to ensure that there's backup provisions for those patients. I'm meeting with the team from Dream this week to discuss about the impact, because there are a cohort of patients that do seem to be frequently perpetrators of AVH. and they are particularly vulnerable themselves in the community, and we're looking at a piece of work that we can do with community teams to ensure that we've got that safety net in, because otherwise they are just going to keep representing and coming in probably through the emergency route of having a life-threatening event. So the complexities are those patients with chronic conditions, complex discharges, patients who lack capacity. So if a patient lacks capacity and therefore does not understand the implications of their behaviour, really what we're doing is then looking at how can we expedite a safe discharge for them? Do we need to involve IDT other community services? And what mitigations can we put in place to protect our staff? That might be additional staff, that might be specialist staff, that might be rotating staff through the area, that might be relocating staff if they've been particularly affected. That might be moving the patient if that's appropriate. And that's an opportunity that rapid reviews look to do. So we're not holding it all the time. The teams are getting quite au fait with managing the situations and escalating the situations. So I would say I've probably had fewer rapid reviews recently than sort of pre-Christmas, but I think that's just because staff are becoming more educated on what their rights are in terms of protecting themselves, how to deal with these situations. So I suppose what I'd like to do is hand it over to you and ask for situations that perhaps I can advise on, scenarios in which you feel could have been handled differently. So yeah, I'll hand it over to you really. Do you have rapid reviews in your areas? Do you escalate? Okay, we'll start from the beginning. If you are encountering AVH and you're not able to mitigate that, you're not able to de-escalate that at a local level, and that continues, or the patient's discharged and you know you're going to be coming back, how do you escalate that? What's your process? Do you, or do you just wait then the patient comes back in and the cycle repeats? It's not okay, but it's okay if you want to share that if that's the situation that you're feeling in. Are there any scenarios where you feel like you can't follow this? I don't think that we lost follow it.
I work at Lindsay Logics Hospital, and we have a lady at the moment who looks like she's got dementia on top of quite very, very severely broken. She's got all those classic dementia symptoms, but the sundown and where she gets really, really quite violent because of the time. And it seems like our wards are quite aware of what we can do and where that can go. But she's in the process of discharge. It's very complex discharge. But it just keeps getting quite stuck.
It is really, really difficult in terms of patients that have a delirium, a dementia, and acquired brain injury perhaps, and that's where then the external support, so the escalation for me would be who else can help with this? Who are the specialists that may be able to advise us on what remedies and actions that we can take? Getting to know that patient really well, looking at those triggers, what can we do differently around that time? For example, one of the wards, we increased staffing between 4 p.m. and sort of 9 to 10 p.m. for a period of time for a patient who we knew would escalate between that time frame. So we were very specific about the times. The training and education really comes into this, and that, these are patients that we regularly present to our organisation, so we have to ensure that we've got the training and education for our staff. E47, as I'm sure some of you will know, is identified within the medicine division as our mental health area. We have specialists working with us within that area, and it's a very different approach to care. We do have a different staffing model there, but you know, often you're trying to protect somebody, you don't want them to fall, you're trying to protect others around, and often what we see is sit down, please sit down, let me take you back to your chair. Whereas it's a very different approach in AVH24. They will encourage mobility, they will encourage engagement, and that can be really hard if you're working in a very hyper-acute area with lots of other things going on. But it's definitely something to think about. Think about the ways in which patients are being cared for. If it is an area like that and you can't dedicate the whole ward to that, are there areas where you could focus with the environment around the needs of people with a delirium, for example? And I think we need to share and learn from those areas that do this, you know, particularly well. And I know that the AVH24 team would be, you know, happy to share their experiences as well.
Some of our regulations and it becomes very college and we understand in those sort of situations that we have several situations that are able to pay for a child and but it's just as important to say that we do this university in the same district, because of the inclusion of the child, and so there needs to be as well if others are able to and but I think one of the things that really resonates is that right with the vision of the I think it was hard to notice that then so not the same children, but family members within the organisations actually don't just see them with the information and the same with our families, we don't have the office and ongoing parents on the mental record because we're not there for the instruments of natural healing based systems and processes of cross-matching in the same way as we should. Yeah, it's those sorts of things, isn't it? When you look at you and not, you're not necessarily medical methods, it's very difficult to experience. Yeah. What we do in ED, we did it on 52-53 for a short time, as we meet fortnightly. And we go through all incidents that have been reported, and a proportion of those will be paediatric ED, as an example. And it's interesting how quickly you get to recognise and learn names as well. So I just wonder if that's a connection that we could do from a PCD, the Children's Hospital point of view. So we literally take an hour every fortnight, go through every incident. We say who we send in an expectations letter to, who we need to have a case conference about, because that's the thing that we do. They might not become inpatients, they might be discharged at that point. And I think that's probably something Kerry we could connect with, so that what we're experiencing with some of our parents, for example, that may not then be admitted at that point, but may come to the Children's Hospital in the future, the team have got that awareness as well. Yeah. Yeah, and that's the thing, isn't it? Because from a safeguarding point of view, we have to have that stance on these AVH incidents, particularly around visitors as well, because if that's how they're behaving with us, and they've got perhaps vulnerable relatives, children, it's a concern about what their behaviour might be outside of the organisation. So we do have safeguarding referrals that come out of the interactive reviews as well. And I'm always aware that when I talk about AVH, I do sort of gear towards the cohort of individuals who have capacity on inclusive class staff. I am aware that I do navigate there. I suppose
in a way, they're actually a little more straightforward to deal with now. We've got the withholding treatment policy. When it comes to visitors, it's a zero tolerance. You ask people to leave. I know it's a little difficult with, young people. It is also like saying, bringing it back to what are the reasons that people are being aggressive and violent? Is there anything that we can do differently? I mean, I don't know if anybody was down in UTU last night, 109 patients, not including visitors, within that very small area that's no bigger than here. That environment in itself precipitates frustration, waiting times 11 hours, things like that. So we have to be cognizant, and as an organisation, we have to work towards minimising what could precipitate AVH. So we are doing some work around the emergency department and the environment. So that's a piece of work. So think about that within your areas. Like I said about B47 being a slightly different environment. Is there something you can do? There's a risk assessment document. If anyone's interested in doing any training around AVH, there's a free course. There are a couple of courses that are provided by the Royal Society of somebody, I'll find out. It was actually really good, but at the end of it, you do a risk assessment of an area. So I chose UTU, went down, literally walked it, spoke to people, asked what their frustrations were, and they've come out with an action plan around some environmental changes that we can work on. So you can do that within your areas. Take a fresh view, ask the patients and the visitors what frustrates them within your areas. Environmental factors are huge, absolutely huge. And I think, sort of picking up on what you're saying, Kerry, as well, and what I mentioned about the contact I'm having with Dream, I am really worried about the health impact of people that cannot access our organisation. I am not going down the route that we shouldn't do that, because ultimately your safety is paramount to me and the rest of the organisation. But we do have to do something differently for people that we are saying you can't access our organisation, because it's only going to get worse for them if we don't help. We're not taking responsibility for their care, but we just need to be aware of what support's available for them. And like I said, if they need referring to another organisation. Now, King's Mill tends to be the organisation that we refer to because it's close, and that's where the cohort patients I've experienced live within that sort of vicinity between here and King's Mill. And so we've got working relationships with King's Mill. I'm sure at some point they will say no, Vicky, it's just not. As I keep picking up phone up and saying, please can you refer this patient to you? You can't finish just because of their behaviour. But you do see changes, I will be honest, you do see changes in behaviour. So the patient I described it a little while ago, after you've been spoken to, I mean, 3 are paperwork at me and everything, but after you've been spoken to for a period of 3+ days, his behaviour did change. Now, unfortunately, then he was readmitted to A&E and it started again. But, we do see an improvement. The police have been really supportive. They've come in and had conversations. So some people really respond to authority. So that works with him. If his behaviour starts to change, we'll say, we'll get security, we'll get the police, and his behaviour does change. It's something ingrained in some people. Are we going to change everyone? Probably not. If we can help them just adjust their behaviour, then that is what's needed. But yeah, it's not easy. But we'll keep working at it. We will get things wrong, but we will try and rectify them. Neil mentioned about the body cams. We're having even more body cams shared, so you will see more and more body cams coming. We don't have them on every single ward, but there will be bases across both city and QMC where if you need one, the information will be out there and you can access them. Just to say as well, City Queens, more reports from Queens than City, it is disproportionate. So I don't fully believe that we're not getting the level of incidents at City. I know that obviously the services are slightly different, but I would expect to see more reports from City. So whether those of you that work for City are just a bit more tolerant, I don't know, but I would say please report as well, because then we can, put the same amount of focus over at City that we sometimes have over the site differences. We do have lots of different things going on in terms of wellbeing. So we've introduced Medicine Connect, and that's where people can come along and talk about their concerns. They can find information about education. It's not just AVH, it's generally. We've had 2 runs of it. It was at City last month. It was at Queen's this month. Police are supporting that. Police are also coming around. We did a walk around at City not too many months ago. That was interesting. I was waiting at the front doors and somebody thought I was being arrested. So, what was that route that you straight went to? Oh, because being arrested. But we did walk around, so staff found it really helpful. So that is something the community teams will come and speak to your staff if that's something that you would like support with. Is there anything? So we do something within our own organisation. I haven't dealt with it. I've not had anyone ask me from an external organisation. I think it comes through more from the community in terms of a safeguarding alert that this person might access your service. They have previously done A, B and C, put an action plan in place. So with our yellow and red warning, the yellow lasts for 6 months. We meet, so it might be myself, Sharon and Neil, Mark Security, or someone else that's been involved, and we will review to see if we take that off, so it doesn't stay on forever. So people aren't sort of tarred with perhaps a behaviour that they have changed from. The red is 12 months, but we can review that before. So there are opportunities. Interestingly, I met with Neil Mark yesterday morning. Was it yesterday? It's only Tuesday, isn't it? Yeah, yesterday morning. And we were talking about some reciprocal opportunities like restorative justice type thing. So we're going to be exploring that. Neil might not have already been in contact with the other Neil, but we're going to look at whether there's something we could do. So where we could have an opportunity to share with the individuals that have been aggressive towards us about the impact that's had, how that's made us feel, and whether there's something we could do about our warning letters to say that actually with a yellow warning letter, if you attend this session with us, then we may consider rescinding that, but that would always be liaising with the people that have been affected. So we are looking at doing things slightly different, but I don't know of any requests from another organisation. I do think we're leading the way a bit from an AVH point of view in terms of the actions that we're taking. This is still relatively new around the rapid reviews and case conferences. It's only really in the last year. So, yeah, lots of things coming up. Is there anyone else?
If they have capacity, patients can change their behavior if you help them understand that this behavior is not going to improve their treatments or the speed of their treatment. So I think if we can find ways and means to show them that this is not necessary, I think they would be able to eventually turn to this end.
Yeah, and that was sort of just this type approach is what we're looking at. So there's opportunities for education, learning from the impact that it's had on people. And it can, and sometimes you see it in short snaps, like I said with the patient I was describing. You speak to him, and for days or even weeks, he will change his behaviour. And then something will happen, and you slip back to that. And it's around frustrations, it's around waiting, it's around not getting always, the response that we would expect. So the teams are getting to know that, and the more the teams are learning about him, then they're managing that situation. But I hear what you're saying, and that's why we're looking at these different ways of reaching people once they've left the organisation as well, to be able to say, look, we want you to have the care you need, but these are the expectations. What do we need to do to help you to, realise that? And also, what are we not doing right? So learning from, what we might have had in terms of the environment, the waiting times, or, the frustrations.
How do you determine whether someone's behaviour is a one-off incident or it's a pattern of behaviour that you need to act on? Do you act on a one-off, or do you need to know whether this is going to be?
We know through datexes, so that's why it's so important to report them. If somebody has a verbal altercation with you and you look at the situation and you think they were grieving, they were really anxious about their child's health or something like that, I think we all recognise that, and we can adjust to it. You might need to have that conversation and datex it to say verbal conversation had with patient or visitor about their behaviour. But it depends on the seriousness of it. If it is deemed so serious, if it is, a hate incident, if it is a physical assault, then we need to deal with that in the moment and then follow that up. We sometimes find out through then our liaising with police, mental health services, community partners, that actually there is a pattern there, and then we put a case conference and we can make a decision. There are some single occasions, but in my experience, there tend to be multiple incidents. And like I say, Sharon and I meet on a 6-monthly and 12-monthly to review those alerts. So we'll know as well. And we check the systems. Nerve Centre might have an alert on to say go with 2 people. There might be a safeguarding. So already you're thinking this might not be a single event. But the only way we know that is if people report it. So the more people report, the more we'll know, and then we'll put the appropriate actions in place. And if you don't feel that there's an action plan or appropriate things in place, escalate it to your line managers and your divisional teams.
Thank you. How do you feel about the pictures of people in the companies in protecting them?
So sometimes I get data texts where the people's details aren't written in and that we do know them. So I'll go back to the team and say, please fill them in. And we've had to ask for security's assistance with that. So if you put the date and time, they'll be able to see if there's any CCTV footage that could be used to help identify a person. It is difficult if we don't have those details. Sometimes we have to do a bit of investigation ourselves. So, for example, in a case where maybe a child's presented with some relatives and we've had to do a safeguarding referral and then look at who were the relatives that were in attendance at that time. We might not have their names, but we usually would have whoever's got the parental sort of supervision there, and that then gets handed over to safeguarding and potentially the police, depending. Sometimes we never know. Sometimes we don't know, and that does make it difficult. But yeah, that is something that people do miss off, is when we do have identifiable information, they don't always include it. So just another miss. There is a bit of a reluctance around paediatric ED in terms of reporting because, obviously everything you described around the families, the children, we obviously try and take into account what might have aggravated the situation. But like I said, there might be a safeguarding element behind that we do need to be aware of. So reporting it, we might not take any action, and that's why the fortnightly meetings are really helpful, because we go through what might have caused that. So staff still report it as an AVH incident, but it doesn't mean we'll take specific action, it's an opportunity for us to then go through and understand and look at that. But yes, if there's anything, you know, if you need any paperwork or anything like that, I can share it again. If you need to know who to speak to, I've probably spoken to them at some point and harassed them at some point to give them some support and help. But it's a huge team effort. I keep saying I, and it's not, it's we. It's a huge team effort to make this work for our teams. It relies on people reporting it, and then it relies on us reacting to it. So if people don't react to it, escalate. That's what I would, you know, just repeat that message. We have an AVH medicine divisional meeting. I'm not sure if all of the divisions have that. If we don't, it's probably worth something that you could explore. We talk about all the AVH incidents we've had, what measures have been put in place, what we need to do differently, what training's missing. And that's where the ideas come through around the restorative justice, the work with Dream around community services. So thank you very much for your time.